So welcome again, everybody. Now it's time for our first keynote presenter. And we are very honored to have with us today Dr. Gilbert Welch. He's been a practicing internist for the last 25 years and a professor of medicine at the Dartmouth Institution of Health Policy and Clinical Research. He is also a world-known author of 3 best-selling medical books, such as Overdiagnose and Less Medicine, More Health, which is also the topic of his talk today. Dr. Gilbert Welch, welcome.
Thank you very much. Thank you. I'm an American. Okay, just checking. And so I don't know a lot about the Nordic Congress. So naturally, I went on the web, and I saw you use some unusual technology here. What is that about? And then I went, wow, unusual costumes too. Look at that. I mean, unbelievable. And sir, if you're here, I just want you to know, 30 years ago, I had some pretty silly-looking clothes myself. And oddly enough, 30 years ago was actually my first visit to Iceland in 1987 with my wife. It was our honeymoon, believe it or not. This is what we did in our honeymoon. We attempted to drive around the island. Now, as you know, the island is bigger than Denmark. What you might not know is most of the roads were dirt. And we were doing it in November. And there was snow. There was an unplowed road, and there were no guardrails. And this part was particularly, oh my God, it was white-knuckle driving. And then this day, we didn't see anybody. There was nobody on the road. I thought, oh my God. And then I found this farm stay. This is on the Arctic coast. And I saw what I was really looking for, a geothermal tub. And here I am, running, and there's my wife, and I couldn't quite get there in 10 seconds. You remember those mechanical timers on that? I couldn't quite get there. But I tried. I tried. But it was good. Now let me take you 60 years ago. And that is me. And I know I have experienced clinicians in the group. And I know many of you are noticing there's something wrong with that child. Now first, the child's clearly overweight, right? That goes without saying. Probably has toddler hypertension, hyperlipidemia, glucose intolerance, right? That's a safe bet. But then look at that face. American pediatricians have an acronym for this. It's a FLK, a funny-looking kid. I undoubtedly have a bunch of single nucleotide polymorphisms, maybe a couple of genetic variants, and maybe even a frame shift mutation. But the real question is, what is going on in there? Oh my gosh. Could that be an early abdominal aortic aneurysm? Man, I am so glad I was born 60 years ago. I'm going to talk to you today about 7 assumptions that drive too much medical care. And actually, I'll probably only get to about 5.5 given the time constraints. But I want to start with a disclaimer. And I'm a conventionally trained physician. I believe medical care can do a lot of good in selected settings, particularly in the care of the acutely ill or acutely injured. But at the same time, there's a growing recognition that the conventional concern about too little medical care needs to be balanced by a concern about too much. A recent survey of American primary care physicians revealed that nearly half of them thought their patients got too much medical care. So here's the challenge I'm going to give you, is can we communicate the nuances of medical care? that some is good, but more is not necessarily better. Now, one other disclaimer, I have a book on the topic. It's called Less Medicine, More Health. And in the vernacular of my current president, it's a great book. It's a fabulous book. You really ought to read it. I have other books on the topic, Overdiagnosed, Making People Sick in the Pursuit of Health, and Should I Be Tested for Cancer? Maybe not, and here's why. And I want to say these two books have lots of numbers, charts, and graphs. And my editor said to me, you know, that scares off about 3/4 of the population. Write a book that doesn't have numbers, charts, and graphs. So this book could be entitled Less Data, More Narrative. Did I mention it was a great book? And if all this is beginning to feel like just another medical advertisement, I want to be clear, I have no financial interest in any of these books. I made that decision back with my first book, Should I Be Tested for Cancer? And the reason is because there's enough money in American medicine already. I didn't want to be questioned, are you saying these uncomfortable things because you're just trying to sell books? All right, let's get going. Assumption number one, all risks can be lowered. And of course, medical care can reduce some risks, but the effort is most likely to be successful when the underlying risk is high. Consider someone with a really high chance of something bad happening in the next 5 years, like 50%, something like a heart attack or a stroke. Sometimes medical care can dramatically lower that risk, even cut it in half, as this is a treatment of really, really high blood pressure. But the reality is most of us are not at that high a risk. Our risk of something bad happening in the next 5 years is on the order of 2-3%. And it's hard to lower an already low risk. And all of our interventions pose some harms. Medication side effects, complications from procedures, even death. Now, the importance of baseline risk first became evident in the treatment of high blood pressure. And now I'm going to show you a somewhat complicated graph of the effect of treatment across the spectrum of diastolic hypertension. I'm going to show you 4 randomized trials. And on the y-axis here is the annual rate of death or end organ damage. Things we care about, heart attack, stroke, renal failure, congestive heart failure. And I'll show you the untreated group of the randomized trials first. This is very mild blood pressure elevations. This is mild blood pressure elevations. This is moderate blood pressure elevation. And this is severe blood pressure elevation. And what we're looking at here is the spectrum of baseline risk from very mild to severe hypertension. I told you they're randomized trials, so let's look at the treated groups. The treated groups are in yellow. And the benefit of treatment, of course, is moving from the red bar to the yellow bar. That difference here, the so-called absolute risk reduction. And this is a little bit of a noisy graph, so let's just look at treatment benefit. And maybe this is a long run for a short slide. But who really stands to benefit from having their high blood pressure treated? Someone whose blood pressure is really high to begin with. I think that's a very important relationship in medicine. All I'm saying is the benefit of treatment is highly related to the spectrum of baseline risk. So let's look at that in a more general setting. That's treatment benefit. And then I raise this point that all of our interventions pose some harm. So I need to have a harm curve up there. I'll start by drawing it here. I want to acknowledge there's some uncertainty about exactly what the slope is. I'll make it wiggle a little bit. And then one of you will point out, no, that should be with downward sloping, because who's most likely to suffer harm from having their blood pressure lowered? Well, someone whose blood pressure isn't that high to begin with, who then gets hypotensive, falls, breaks a hip, goes in a nursing home, etc. Be that as it may, my main contention here is that harm is less tightly related to the spectrum of baseline risk. It's more a fixed effect of treatment. If that's true, there's an area certainly for net benefit, but at least we ought to conceptually worry about an area of net harm. Now, the importance of baseline risk is obscured by our tendency to describe the benefit of intervention in relative terms. And this brings me to a couple of advanced concepts. Subtraction. Oh, you guys haven't had that? And division. Oh my gosh, this could be tough. All right, let's see how you do, okay? Let's say you're buying a car that lists for $50,000, but you get it for $25,000. How much did you save? Well, do the subtraction. How much did you save? In euros. Oh, okay. Yeah, $25,000. That's easy. Now, do the division. How would we typically say how much you saved? Yell it out. 50% off. Sure, 50% off. So the subtraction is the absolute change. The division is the relative change. Now that we're all warmed up, let's say you're buying a popsicle list for $2, but you get it for $1. How much did you save? Well, do the subtraction. How much you save? $1. Do the division. How much did you save? And there you see the problem, right? There you see the problem. That relative change provides no information about the question 50% off from what? And the thing I want physicians and patients to consider is we don't have a lot of 50% off sales in medicine, right? We're lucky if we're talking about 10 to 20% off. And the question to really ask is, am I being offered 10 to 20% off from here, or am I being offered 10 to 20% off from here? It really matters. Oh, and just to add one more complexity to this graph, the number of affected individuals rises steeply as you go down the spectrum of baseline risk. There are not that many patients with severe blood pressure elevations, but there are loads of patients with mild blood pressure elevations. And this isn't just about hypertension. This could be about diabetes, a spectrum from borderline diabetes to severe diabetes. And when I was a resident at the University of Utah, our goal for type 2 diabetics was to try to get their hemoglobin A1C down to 7 to 8%. And then someone said, no, that's not right. What you should do is to try to get it down to normal, under 6%. Now, what is the effect of a decision like that? Well, up here you say, first you've got a whole lot more patients to treat. By the way, it may distract you from the patients that most need your services. A patient who had a hemoglobin A1C of 6.5% wasn't a patient before, but now they are. And who are these patients? Well, they're the patients that arguably have the least to benefit from intervention and are at the highest risk for net harm. Any evidence of this? Some of you may remember in 2008, the NIH had this press release, for safety, the NHLBI changes intensive blood sugar treatment strategy. Changes. That's an interesting choice of words. Whoa! They stopped it. Why did they stop it? Because it was a 22% increased risk of death associated with intensive blood sugar control, from 60 to 73 per thousand. The assumption is all risks can be lowered, but the disturbing truth is risks can't always be lowered, and trying creates risks of its own. Assumption 2 is it's always better to fix the problem. But that's not necessarily true. Sometimes it's better to manage the problem of heart disease with good food, regular activity, and a few good medicines than it is to try to fix the problem of heart disease by inserting wires, blowing up balloons, and placing stents. A category of procedures that go under the name PCI, percutaneous coronary interventions. Now, I know I'm in a room full of doctors, and I want to be clear. If I'm having a heart attack, I'd like to have the problem fixed. Everybody hear that? I'd like to have the problem fixed. Now, why do I say that? Well, we have a lot of randomized trials in the setting of myocardial infarction. You're looking at a paper from the Lancet right now of 23 randomized trials. You're looking at the relative risk for death, PCI, relative to the best medical care. Here's the summary estimate, which is an R.73, which we've all been taught to interpret as a 27% fewer deaths. Now, you might think, boy, he's already forgotten what he was talking about. That's a relative change. How about the absolute change? Well, it's 7 versus 9% died. And maybe you say, well, that's not that much. But I want to be clear, that's within the next 30 days. I'll take the PCI, thank you. By the way, PCI had 65% fewer second heart attacks. 3 versus 7% had second heart attacks. And PCI also led to fewer strokes and fewer bleeds. So I think it's fair to say percutaneous coronary interventions is a better treatment for heart attack than medicine to dissolve clots. But most patients undergoing PCI in the United States have not had a heart attack. About over 2/3 are elective procedures. Now, the trial that informed us about this group is the so-called COURAGE trial. And the COURAGE trial enrolled 2,300 patients with chronic stable angina, randomized them to immediate PCI versus optimal medical therapy. The findings at 5 years, 19% of patients undergoing PCI had died or had a heart attack, while in the medicine group, only 18.5% had. If anything, it looked like medicine was better. There's no statistical difference in any of these measures, though, so we call them the same. This should be familiar. This should sound familiar to you. Now I've got a spectrum of risk from no symptoms to heart attack, actually having a heart attack. PCI for heart attacks up here. PCI for chronic stable angina is somewhere down here. And probably about 1/3 of PCIs in the United States are down here. Anybody know who this man is? That's former President Bush. Here's a nice picture of him. Let's see. Yeah, there he is. Good-looking guy. He's a very active man. He's still active. He works the ranch. He clears brush. He runs. He's an avid mountain biker. He felt fine. He went for a checkup, and he got a balloon and stent. Now, one of the things that's really interesting about this story is some American physicians were willing to say exactly what they thought. This is the chief of cardiology at the Cleveland Clinic. This is really American medicine at its worst. It's one of the reasons we spend so much on health care and we don't get a lot for it. In this circumstance, the stent doesn't prolong life, it doesn't prevent heart attacks, and it's hard to make a patient who has no symptoms feel better. That's a really important point. It's a really important point. It is hard to make a patient who has no symptoms feel better. The assumption is it's always better to fix the problem, but the disturbing truth is trying to eliminate a problem can be more dangerous than managing one. Assumption 3 is sooner is always better. And we've all been taught that the best way to deal with a feared disease like cancer is to try to catch it early. But our understanding of cancer is changing, and ironically, it's because of our experience with early detection. Now, in the past, doctors treated a population. We didn't use the word population, but each one of those red dots is supposed to represent an individual. But we waited for problems to develop, and then we made diagnoses and treatment. And the early diagnosis ideal was very powerful. It was say, take that same population and advance in time the point of diagnosis and treatment, with the hidden assumption that the natural history of this group would be the group that was destined to develop the problem. But the reality is actually quite different. Whenever we look for early forms of disease, we find more patients. And now we know that natural history must be more complex. What would happen if we did nothing? Hopefully we've got the people destined to develop problems, but as some of you know, we may miss them because they develop problems so quickly. But at the very least, we've identified another fraction of patients, those not destined to develop problems. and they're the overdiagnosed and needlessly treated fraction. We need to think about the word cancer differently. Not all the abnormalities that get labeled cancer will necessarily matter to the patient. And that brings me to the barnyard pen of cancers. And there are three animals in the barnyard: the birds, the rabbits, and the turtles. And the goal of early detection is to fence these animals in. But I think you can see the problem. You can't fence in a bird. The bird is already flown away. And these represent the most aggressive cancers, the fastest growing cancers, the cancers that have already spread by the time they're detectable. Screening doesn't help with the birds. The question is, can you treat them? Now, the rabbits are hopping around, and you can catch them if you build enough fences. And these are the more slowly progressive cancers, the cancers that are potentially helped by screening. And then there are the turtles. You don't need any fences because they're not going anywhere anyway. And the unfortunate reality is screening is really good at finding turtles. But doctors aren't good at distinguishing turtles from rabbits, so we end up treating all of them, and that leads to the problem of overdiagnosis and overtreatment. Now, it's an uncomfortable reality for us, but there's a lot of turtles out there, and the way we know that is from autopsy studies of people who have died from some other cause, and we look hard to see how many have cancer. 1% to 3% of adults harbor unsuspected kidney cancers. That may not sound like a lot, but that's a whole lot more than will ever die from the disease. At least a third of adults harbor small thyroid cancers. About a third of women aged 40 to 49 harbor small breast cancers. And as many of you know, over half of men over age 60 harbor small prostate cancers. Now, I'll talk more about this in a clinical workshop tomorrow, and we'll focus and drill down on the problem of cancer overdiagnosis. But for now, I just want to share with you a paper I had with my colleague Elliot Fisher this week in the New England Journal, where we considered the role of income and cancer overdiagnosis, and we're looking now at the combined incidence in the United States of breast cancer, prostate cancer, thyroid cancer, and melanoma. This is what it looks like for low-income counties in the United States. This is what it looks like for high-income counties in the United States. And at least, in the United States at least, it looks like high socioeconomic status is a risk factor for cancer overdiagnosis. So I hope you look at a headline like this a little differently. Molecular breast imaging nearly quadruples detection for breast cancer. We've all been taught to think that's a good thing. But the minute you understand the birds, rabbits, and turtles, you say, wow, does that just mean we're finding a lot of cancers that doesn't matter? Oh, here's a game changer. Could a bra actually detect breast cancer? That doesn't even look that comfortable, does it, ladies? That doesn't even look... And believe it or not, just 2 weeks ago, a new model came out. Could this bra detect breast? What are we doing? Attaching people to instrumentation to check them daily for cancer? Does that look like the path to a healthy society? Might be a good way to make money. Guys, I have an idea. How about doing this? Could diapers actually detect... Who wants to go in with me? Who wants to join me? We could raise some money here today. The assumption is sooner is always better, and why early detection may make sense in selected settings, particularly people at very high risk for the disease. Its broad spread adoption has been a recipe for making people sick. The disturbing truth is early diagnosis can needlessly turn people into patients. Assumption 4 is it never hurts to get more information. This is the information age. I saw you're all on your smartphones, right? Hold up the smartphone so I can see them. I know you're on them. Yeah, okay, yeah. You can light up the light, yeah. It's an information age. But this term information, we've begun to confuse data with useful knowledge. It's really important to distinguish between the two. It's very easy to collect data, and there are lots of data out there that I could collect on every one of you. There are thousands of bits of metabolic data. Think of all the blood tests we can order. There are millions of pixels of imaging data. We can image you in any plane. We can change the weighting. We can rotate the image. And there are 3 billion data points in your genome. There is a lot of data out there. Oh, and it can be sent to your smartwatch. Who has a smartwatch? We'll send it. No, oh, no one has a. Hey, buy American. All right, so let's throw some technology at the problem. Let's get a simple data point here. And this is a chest x-ray. And as you notice, this is a chest x-ray with someone with an implantable defibrillator or a pacemaker. And it's a relatively easy piece of data to collect to ask the question, how well does electricity flow from the battery pack to the lead in the heart? And in between is, of course, lung. And, of course, we hope in lung there is air. And if there is air, electricity will not flow that well. And that so-called pulmonary impedance will be high. If there's fluid, electricity will flow much better, and the pulmonary impedance will be low. So let's think about the value of this information, and I'll share with you a randomized trial on pulmonary impedance. The objective was to reduce readmission rates by real-time impedance monitoring. The patients were 335 outpatients with heart failure and implantable defibrillators. These were sick patients, people that are in and out of the hospital. Now, the intervention was to turn the defibrillator's impedance monitor on. So everybody had the hardware. Everybody had the same hardware. The randomization was simply to turn on the software or not. And then according to the article, patients with abnormal impedance were alerted with an audible tone. Now that is a very formal use of the English language, alerted with an audible tone. What would most people call that? An alarm, yeah.
Your lung is now filling with fluid. Your lung is now filling with fluid.
I better say, thank you, Siri. All right, let's see how good the Nordic Congress is. What did that do to clinic visits? It increased it, sure, it's 3 times more. Alarms were going off inside of people. What did that do to readmission rates? It went up significantly more. Remember, that was the primary outcome of the study. They were trying to lower admission rates, but no, they were significantly higher. And what happened to mortality? Well, no difference. The data were not useful. Oh, well, actually, there was a slight increase. I know I shouldn't say it. It's not statistically significant. Okay, get it off. I shouldn't say it. But it was going the wrong direction. How about data on cancer metastases? Here the objective is to find cancer metastases early and reduce mortality. The patients are 1,200 men and women with colon cancer. This is not screening. These are people with established colon cancer. The intervention, if you're randomized to the intervention group, you got intensive diagnostic follow-up, specifically looking for metastatic disease in the chest, abdomen, and pelvis. This was basically a total body CT every 6 months plus a CEA level. What do you think? Can we find metastases earlier? Oh, yeah, we can find them early. What does that do to the rate of surgery? Oh, it leads to more surgery. What does it do to mortality? It has no effect. Well, actually, it's a slight increase. I know I shouldn't say it. Actually, it was a slight going the wrong direction. By the way, these are the same findings as a similar trial looking for early breast cancer metastases 20 years earlier. Let's be clear, seeking information about the early signs of metastatic cancer can be very scary for patients. You have a new cough, some general practitioners might say, well, maybe you have a cold. Why don't you take a rest? Take it easy this weekend. Others might go, whoa, that could be a met. Let's get a chest CT. Ankle pain, even though you just started running again after you finished your chemotherapy, some doctors might say, well, why don't you just rest a little bit? Why don't you stay off that ankle? Others might say, boy, that could be a met. Let's get a bone scan. Seeking information about the early signs of metastatic cancer doesn't help cancer patients live longer, but it does scare many. and leads a few to live longer with the knowledge that they have incurable disease. They are then subjected to additional therapies and their toxicities earlier, at a time they would otherwise be asymptomatic. The assumption is it never hurts to get more information. But the disturbing truth is data overload can scare patients and it can distract your doctor from what's important. Assumption 6 is newer is always better. How many of you like to beta test new software, a new medical record with the bugs still in it? Not really good, yeah. Let's consider a new procedure. This is a classic story. Many of you know it's about autologous bone marrow transplantation for women with metastatic breast cancer. There was early enthusiasm. This is a headline from the Los Angeles Times in 1990. Breast cancer survival rate may double, studies finds. 10 years later, there was a sobering reality. To a reasonable degree of probability, this form of treatment for metastatic breast cancer has been proved to be ineffective and should be abandoned. As many of you know, a lot happened during those 10 years. A lot of U.S. insurers got sued because they didn't want to cover what was a very expensive investigational therapy. A lot of hospitals got into the market because it was a very expensive therapy that they could make a lot of money on it. Federal judges, Congress, and the executive branch actually got involved mandating coverage for this procedure. And some 35,000 women went through hell at the end of life. It was a terrible, terrible mistake, one of the worst medical errors on record. How about a new device? This is a AP pelvis film, and I'm not violating any patient confidentiality here because it's my pelvis. And there's my prostate. Okay, maybe it's a little bit bigger than that. I don't know. No, I'm not going to talk about prostate cancer right now. What I want to talk about is hips. One of the more useful procedures we do, hip replacements. And the first thing to know about hip replacements is orthopedists have a lot of hips to choose from. A whole lot of hips. But I want to focus on one aspect of the hip. On the left is the metal on plastic hip. It was developed at the Mayo Clinic, the so-called Charnley hip, and it has a metal ball sitting in a plastic liner with a metal case. And the advance was to get rid of that plastic liner, which allowed the ball to be bigger on the metal on metal hip, which had some theoretical advantages, an increased range of motion, and supposedly would lower the risk of dislocation. And the plastic liner did have a problem. It would wear, and little bits of plastic would come off that plastic liner over the years and would get into the hip joint. Of course, plastic is very inert, and it didn't seem to cause any problems. Now, what's wrong with this picture? Which hip do you want? You want the bottom line? I see someone going like, yeah, it's the bottom line. Yeah, because the metal on metal hip is failing at 7 times the rate as the metal on plastic. Why was it failing? Well, now you have 2 metal surfaces wearing, and in fact, little bits of metal come off and get into the joint. Well, metal is not inert. It leads to what the orthopedic surgeons call a pseudotumor, the intense inflammatory reaction of the hip, and a lot of pain. And remember, that's the reason patients underwent the procedure, was to get rid of the pain. And now they have to undergo a second procedure, which is a much more difficult because it's a reoperation. Now, I'm a proud American. Let me try that again. I'm a proud American. I know you might have a hard time believing that, but I'm a proud American. You know what really angers me about this is these data come from that tyrannical power that taxed us without representation. And yet we've done more metal on metal hips than any other country in the world. Why is that? Because we can't look at our own healthcare system. We have so many payers, we can never get a comprehensive look at what's happening at the system as a whole. And I can't think of a better argument for a single payer system in the United States than simply to have a single data system, so you know how the system is functioning. By the way, metal has a way of going into the blood. You got metal ions in the blood. Could that be a problem? Metal, it's usually not something we like in the blood. And unbelievably, on the same day in 2014, both the Lancet and the New England Journal shared case reports of the problems. Let me just share with you quickly the New England Journal case report. It was a woman in her mid-50s who all of a sudden developed congestive heart failure, severe congestive heart failure. It was such a bad cardiomyopathy, she underwent cardiac transplantation. And then a few months later, the transplanted heart started to fail. Now that shouldn't happen. Right, the heart's coming from a healthy, presumably young donor, and it's failing. And this really threw the doctors off until they realized she had a metal-on-metal hip. Someone said, we got to measure some metal levels, and her serum cobalt level was 300 times normal. Don't miss the fact that is one device causing two hearts to fail in the same patient. Oh, and how about a new drug? You remember Vioxx? Did that get to the Nordic countries? Maybe not. Well, this is how it's advertised on the internet now. Vioxx, arthritis pain alleviated even if it kills you, reflecting its higher cardiovascular mortality. Anybody remember this song? You were listening to the news? I want a new drug. I don't want a new drug. I want an old drug. I don't want a new procedure. I want a procedure that's known to work. And I don't want a new device. I want a device with an established track record. Because the disturbing truth is new interventions are typically not well tested and often wind up being judged ineffective, even harmful. Well, the last assumption is it's all about avoiding death. And I want to be clear, we're entering what I call value judgment territory. We can all have different feelings about this, and of course it's a very personal kind of issue, how you value these things, but I'll share my values with you now. First, many of us were drawn into medicine because of our interest of saving lives. And I'm no different. This is a picture of me in 1975. In my hometown of Boulder, Colorado, and I was an ambulance attendant for the local ambulance company, and as you can see, I thought I was pretty cool. I don't know if you can see up there on the high decks, but you're probably wondering, well, what's that thing there? Is that a pocket protector? That's not cool, right? That's not very cool, but I thought I was pretty cool. And in fact, one summer while I was working, this song came out. We'd be driving around town, shoulders out, yeah. It's so cool, we're saving lives, right? That's what it was all about, saving lives. And then we think about these words, saving life and avoiding death. They're very powerful phrases, aren't they? Saving lives and avoiding death. But they're shorthands for far less evocative phrases, lengthening life and delaying death. And if you feel the difference between the words in the blue, if that sort of strikes you at your core, I think you know what I'm talking about, that how the change in language may make you feel differently. And the question I have is length of life the only relevant variable? Sometimes it seems to be when we're judging research, that's all we're looking for, is whether it changes the length of life. But maybe the quality is really important too. This is a social networking site for physicians called Sermo, which asks doctors this question: which of these diseases are you personally most afraid of developing or contracting? Notice the most common cause of death, they're not worried about it. What are they really worried about? They're worried about living too long. That's what they're worried about. It's all about avoiding death. Is that really true? If that's true, why don't we lower the national speed limit back to 55? In the United States, during the oil crisis, we lowered our speed limits from 70 to 55 miles per hour. And the National Highway Administration estimated it saved about 3,000 lives a year. I can tell you, most Americans would not want to do this. Why do we climb mountains? This is a picture of my wife. We're in the Alaska range where we met, and it was one of the greatest trips of my life. But why do we, if it's all about avoiding death, why would we do that? Why would we drive around Iceland in November? I mean, really, what was that about? No guardrails. Here's our car at the end. It was a Subaru. We broke the door, got caught in the wind, but we made it. We made it back to Keflavik. And why do we swim in the oceans? Full disclosure, I love to swim. I love getting in natural bodies of water. And so I went to the Centers for Disease Control, and I looked to see how many Americans die in natural bodies of water each year. These are not boating accidents. These are not swimming pool accidents. These are swimming at beaches, ponds, creeks. And the number is 1,500. 1,500 lives a year. What's the correct policy response? Is it to close the beaches? I don't think so, and I don't think you think so either, because you know the disturbing truth. A fixation on preventing death diminishes life. I want to come back to where I started. Medical care can do a lot of good in selected settings. I know that's true, particularly in the care of the acutely ill and injured, what you might call acute care medicine. But at the same time, in many other settings, we've exaggerated the benefits of medical care and we've understated its harms. And the question I want to leave you with is communicating this nuance part of our job. Thank you very much for your attention.